This is the case of a patient with bilateral anterior choroidal artery aneurysms. This is a 55-year-old woman with 5 weeks of left-sided headache and a particularly severe headache approximately 9 days prior to admission that was associated with loss of consciousness for which she did not receive any medical workup. On the day of presentation, she again had a sudden onset severe headache that caused her to present to the emergency department. In the emergency department, she was diagnosed with a Hunt and Hess Grade 2 Modified Fisher Scale Grade 2 subarachnoid hemorrhage. In terms of past medical history, the patient's history is significant for hypertension. She does not have any family history of aneurysms or vascular disease. She is a heavy smoker and has a history of prior heavy alcohol use. On examination, the patient is awake, appropriate, fully oriented, able to follow complex commands. All cranial nerves are intact, including intact pupillary reflexes. There is no peroneal drift, and she is able to move all limbs symmetrically with full strength. In terms of initial management, the patient was admitted from the emergency department to the neurosurgical ICU. Blood pressure was tightly controlled within a cardipine drip for a MAP goal of less than 110. Various medication prophylaxis was initiated, including nimodipine at 60 milligrams every 4 hours, Keppra at 1 gram every 12 hours, and given that there would be some delay before the patient's definitive treatment, the patient was started on tranexamic acid at 1 gram every 4 hours to help prevent rebleeding from the aneurysm. Given that the patient had hydrocephalus on initial head CT, an external ventricular drain was placed at the bedside in the ICU. The patient went for a CT angiogram and then a formal catheter angiogram the next morning. On the initial CT, the patient had enlarged ventricles and blood in the subarachnoid spaces, more localized to the left side than to the right side. On CT angiogram, the patient was found to have what appeared to be bilateral aneurysms of the supraclinoid carotid segments, with the left-sided aneurysm being slightly larger than the right-sided aneurysm. This led to the performance of a catheter-based cerebral angiogram. On the right IC injection, the patient was found to have a middle cerebral artery aneurysm as well as an anterior choroidal artery aneurysm. On the left side injection, the patient was found to have a larger, more irregularly appearing anterior choroidal artery aneurysm that localized near the area of subarachnoid blood on the non-contrast head CT. So in summary, the patient was found to have a right anterior choroidal artery aneurysm measuring up to 5.5 millimeters, a right MCA aneurysm measuring up to 5 millimeters, a small left superior cerebellar artery aneurysm measuring 1.4 millimeters, and a larger 5.6 millimeter left anterior choroidal artery aneurysm that was much more irregular appearing and multilobulated than on the right side. Given that this aneurysm localized to the point of most intense blood on the non-contrast head CT, this aneurysm was believed to be the cause of the subarachnoid hemorrhage. This aneurysm was as well closely associated with the origin of the anterior choroidal artery, and it was not felt that an endovascular approach to the aneurysm would allow for preservation of the anterior choroidal artery. Again, three-dimensional rotational angiography demonstrates the relationship of the anterior choroidal artery to the neck of the aneurysm, demonstrating that complete coil occlusion of the aneurysm would place the anterior choroidal artery at risk. The patient was thus managed via a craniotomy and clipping, and the patient was taken from the angiography suite to the operating room, where the patient underwent a left frontotemporal craniotomy with a posterior and lateral orbital osteotomy for clipping of the ruptured left anterior choroidal artery aneurysm. During the procedure, temporary clipping was performed of the left internal carotid artery. The patient underwent an intraoperative indocyanine green injection to confirm vessel patency and aneurysm clip occlusion, and then a formal intraoperative cerebral angiogram to more definitively confirm vessel patency and full clip occlusion of the aneurysm. For positioning, the patient was positioned supine. This is a different patient than the patient in this case to demonstrate positioning in the incision. And the typical curvilinear incision in the left pterional region was performed. A right radial artery sheath is placed, and the arm is placed on a separate arm board for performance of the intraoperative cerebral angiogram. After a left-sided craniotomy was performed, the sphenoid wing was drilled flat, and the posterior and lateral orbit was removed in order to decompress the supraorbital fissure and perform a partial extradural clinoidectomy. The dura was opened, and the following operative video ensued. Here, the dissection is started by opening the sylvian fissure from distal to proximal, using sharp dissection with the arachnoid knife, spreading with bipolar cautery forceps, and micro scissors. Once the sylvian fissure is open, the optico-carotid cistern is identified to allow for egress of CSF and brain relaxation. Here we are further opening the optico-carotid cistern, exposing the ipsilateral optic nerve and carotid artery. Here the middle cerebral artery is being exposed at the carotid artery terminus, staying more medially on the carotid artery as the aneurysm is projecting laterally, and now the aneurysm neck is dissected out from the lateral surface of the carotid artery. Here the aneurysm comes into view. Notice the irregular blebs and daughter sacs of the aneurysm, and then finally at the neck of the aneurysm, the anterior choroidal artery is identified. Again, full dissection of the aneurysm neck is ensured. And in this case, a slightly curved clip is placed on the aneurysm neck, avoiding the origin of the anterior choroidal artery. And indocyanine green angiograms are formed demonstrating patency of the carotid artery. Here you can see the origin of the anterior choroidal artery filling nicely with the indocyanine green, and there is no residual filling of the aneurysm neck or aneurysm sac. At this point, the incision is temporarily closed and a formal intraoperative angiogram is obtained. In the lateral view, no residual aneurysm can be seen filling, and the anterior choroidal artery is seen filling nicely here. For the patient's postoperative course, the patient developed moderate vasospasm of the supraclinoid left ICA and left A1 approximately 5 days after the clipping. Improvement in vesicaliter was obtained by taking the patient back to the angiography suite and doing direct injection of intraarterial verapamil into the supraclinoid carotid. Eventually, the EVD was able to be weaned and removed on post-clip day 10. The patient was able to transfer out of the ICU on post-clip day 11 to a step-down unit and was able to discharge from the hospital at day 13. Approximately 2 months later, the patient was evaluated in clinic for elective treatment of her residual right anterior choroidal artery aneurysm. Again, this aneurysm is approximately the same size as the left-sided aneurysm and also has irregular blebs, but was not believed to be the source of the initial rupture, and so this was left for elective treatment. This aneurysm was managed with a pipeline stent, and the patient, being approximately 3 months status post the clipping, was then placed on dual antiplatelet therapy with aspirin and Plavix. The procedure was done via right femoral access. A microcatheter was able to be advanced into the right carotid siphon and then ultimately into the proximal right middle cerebral artery. A pipeline flex device was able to be deployed across the aneurysm neck with the distal landing zone of the stent in the proximal M1 and the proximal landing zone of the stent in the cavernous carotid artery.